In 2005, there was research documenting that a SNP on CYP2D6 impacts tamoxifan's efficacy. For those of you who have women on tamoxifen, tamoxifen is a prodrug. It is not the active molecule that acts as a selective estrogen modulator in a woman's body. It is called indoxifen, and it has to undergo a biotransformation in CYP2D6. If you have a SNP on CYP2D6, it does not work. So a woman could be on tamoxifen for 3-5 years, and if she has a SNP on this particular enzyme, it does not work for her. She is not getting the benefit of what the physician thought it would. Very, very powerful information. Particularly now that women are also, I don't know about you, but I've been seeing a trend. Those breast cancer survivors who are on tamoxifen are actually being changed to the aromatase inhibitors. And as a consequence, because of this information that just came out, showing that women who have been on tamoxifen for 5 years have not received the benefits that they've been looking for. Aromatase inhibitors also have to undergo a biotransformation in the body, in the liver. So if you have a SNP on that particular enzyme, you're not going to generate the aromatase inhibitor activity that you're looking for. So here again, we balance this out by not only knowing what's going in, but how effective it's going to be in that woman's body. This is the research that was published in 2005 showing that if you were heterozygous, meaning that you had one SNP on one chromosome, you had less activity of tamoxifen, two times less than the wild type. Wild type is where you have no SNP at all. If you were homozygous, meaning that this SNP occurred on CYP2D6 on both chromosomes, you were 4 times less likely to get the conversion. Very significant numbers. So the clinical implications here are that anyone who's taking tamoxifen needs to be monitored as to how they're converting that molecule into something that's efficacious to their body. As Dr. Taylor talked about, where he had the HRT and the anxiety and depressive medications in the middle, oftentimes women who are on tamoxifen are prescribed SSRIs, selective serotonin reuptake inhibitors, things like Paxil and Zoloft. In the case of Paxil and Zoloft, they inhibit this particular enzyme. So you could have a functioning enzyme that would convert tamoxifen to endoxifen, but if you add another drug to that, it inhibits the conversion of tamoxifen to endoxifen. We're drilling down to be very specific about each individual in their prevention and treatment programs. How many people are familiar with Oncotype DX? Excellent. We have a few in the middle here. For those of you who are working with breast cancer patients, I really encourage you to check out the website called genomichealth.com. This is a test that has been recently put on the market for individuals who have been recently diagnosed with breast cancer. It will, if you get, there is a regression curve that they use based on the 20 and 30 years experience of women being on tamoxifen, wherein a woman can avoid, if she has a low recurrence score, she can avoid surgery, chemotherapy, or even radiation.
What's the website again?
Oncotype DX at genomichealth.com. This is a very, very valuable tool for a clinician because it's looking at the DNA of the tumor. And by uncovering the DNA of the tumor, you can identify, one, what induced the tumor in the first place, and secondly, how best to treat that particular patient. It's generally considered about 100,000 out of the 220,000 women every year would qualify for this, because this is the criteria that you need to meet. If there's node involvement, it's not a good idea. But if there is no node involvement, ER positive in either stage 1, stage 2, get that pathologist to order the Oncotype DX. Some insurance companies cover it, others do not, but it is valuable information for that woman if she wants to avoid chemo, radiation, or surgery. These are the various genes that the Oncotype DX looks at, including the HER2, which is very valuable information because, again, it's a differentiation process that allows the clinician to make the best decision for that particular patient. This is the reoccurrence score, and this was the reoccurrence score for a patient of mine who got a 6. Again, what they do, this is a regression analysis. So here's your curve. Basically, she has a 5% chance here, and her score was 6. With that low score, all she would need to be on is tamoxifen. No surgery, no chemo, no radiation. With that information, then, you can inform the oncologist that it's probably not a good idea to put somebody on a chemotherapeutic agent for 3 or 5 years when this will suffice. I have a patient in New York who was diagnosed with breast cancer in August. Unfortunately, the oncologist, even after looking at her recurrence score, which was 12, right over here, right there, very low, insisted that she do chemotherapy and radiation.
Insurance.
Somebody said down here, insurance. Yes, that's a possibility, but we also know that breast cancer or any cancer is big money. And it keeps the wheel moving. So when you introduce something like this, it has to be for the patient's best interest, not the interest of the oncologist's pocketbook. But we won't get into the political part of this until later. I want to show you one other example of where tumors and the DNA of that tumor can be very, very valuable. Herceptin is a drug that is used usually in the treatment of an individual who has a tumor that has been identified as ER2. If that individual has a SNP on that tumor that expresses this particular protein, a shortened form of the receptor, it cannot bind to the Herceptin. So by knowing that in advance, what we can do is recommend that the Tykerb, a drug that will respond to that particular receptor, be the approach for that individual.